Hi, everyone. My name is Jennifer Sherman, and I am the staff attorney for legal advocacy at the American Diabetes Association. I'm joined with Dr. Henry Rodriguez, professor of pediatrics at the University of South Florida College of Medicine. Dr. Rodriguez is also the co-chair of our ADA Safe at School working group. Thanks for taking the time to join us today to learn about Diabetes 101 for students with diabetes in schools. During this presentation, we're going to go over diabetes basics, legal protections for students with diabetes, and what types of reasonable accommodations should be put in place to ensure that students receive needed care and are treated fairly. While the American Diabetes Association attempts to ensure that all information is accurate and current, this general information about potential legal protections and medical best practices is not a substitute for individualized legal or other expert advice or assistance. The American Diabetes Association, its staff and volunteers do not provide legal or medical advice or represent you. For detailed legal advice or representation, contact and consult an independent attorney, and for healthcare consultation and advice, consult with your professional healthcare provider. So first, let me go over what the American Diabetes Association Safe at School campaign does. Our Safe at School campaign is based on 3 principles regarding diabetes management in school, which we'll get a little bit more into later, but just to say what those are, is that all school staff members need to have a basic knowledge of diabetes and know who to contact for help. This means at a minimum, everyone who has custodial responsibility for the student should understand diabetes and know how to recognize a low and know how to get help. Second, the school nurse is the primary provider of care for diabetes, but other school personnel must be trained to perform diabetes care tasks when the school nurse isn't present. These tasks include insulin and glucagon administration, blood glucose monitoring, carb counting, and recognition and treatment of highs and lows. Third, students should be permitted to provide self-care whenever they are at school or school-related activities. This applies to students who possess the maturity level and skill set to do so. So the organizations listed on the slide, I won't read them all, agree with the Safe at School campaign goals and principles that I just spoke about, because these goals and principles help foster a safe environment for children with diabetes at school. So here's an overview of what we know about diabetes in the school setting. First, diabetes requires 24/7 management, and students can never take a break. Second is that parents and guardians should work with their child's school to ensure a smooth coordination of diabetes management between home and school, since that care is 24/7. However, we recognize that the home and school settings may vary. For example, parents may change their child's pump infusion site at home. We'll get a little bit into what that means in a second, but staff could elect perhaps to use a backup plan for insulin pens in case of a pump malfunction. Parents and guardians might be able to make treatment decisions based on continuing glucose monitoring data at home. And while the staff might still use that same data, they might not be responding to every single data point like a parent would. Parents and guardians need to make sure that the school has all the supplies needed to care for their children, and fluctuating and out of range blood glucose levels may negatively impact learning and behavior, which is important to note. And finally, written care plans are essential. Parents and guardians should make sure written care plans, including a diabetes medical management plan, are developed before the school year begins or before the student returns to school after a diagnosis. So some goals we have for the safety and inclusion of the student. Schools must provide a medically safe environment for students with diabetes. Students with diabetes must have the same access to educational opportunities and school-related activities as their peers. And schools should work with parents and guardians and the student to reasonably support daily diabetes management activities. I'll now pass it off to Dr. Rodriguez to go over what diabetes is and how it's managed.
Thanks, Jen. So As Jen mentioned, I'm a pediatric endocrinologist and I'm a clinical director here at the University of South Florida, and working with the Safe at School working group at ADA. We've really focused on developing tools and resources for staff at schools to assist in the management of students' diabetes. And so first I want to acknowledge and thank you all for attending, because I think this is critically important for really the success of all students that are affected with diabetes in the school environment. So if we look at the number of individuals that are affected by diabetes under the age of 20 in the United States, it's currently over 350,000. And if you look at this graph, it lists from 2001 to 2017, you see that there are increasing prevalence both for type 1 there on the left and type 2. So we're seeing more and more students for which this is a critical issue. If we specifically look at what diabetes is, really diabetes is high blood sugar. And so in diabetes, the body does not make or properly use insulin. We're going to get into that in a moment. But insulin is needed to move glucose that comes from the digestive system into the bloodstream, to move that glucose from the bloodstream then into the cells. The cells require glucose as their energy source. And if there's not enough insulin, if the insulin doesn't work appropriately, then high blood sugars result. And those high blood sugars then give rise to symptoms that may include low energy levels, dehydration, and complications, as we'll get into in a moment. So if you look at type 1 diabetes results from autoimmunity. An autoimmune disorder occurs when the body's immune system, which normally protects us from germs, bacteria, even cancer, essentially malfunctions, and it begins to target part of the body itself. In the case of type 1 diabetes, the body targets the insulin-producing cells in the pancreas. When you no longer have sufficient ability to make insulin, that then gives rise to higher blood sugars. And so these students require daily insulin for survival. And it's historically, type 1 diabetes has been felt to really be a juvenile pediatric disease, but honestly, there are currently in the United States more individuals that have type 1 diabetes that are adults than children, but it can occur throughout the lifespan. And it is, however, the most common type of diabetes in children with adolescents. In the case of type 2 diabetes, it is really a consequence of insulin resistance. So an analogy or an example I typically use with families is understanding that all the cells require glucose or sugar that comes from the bloodstream. If you imagine that every one of those cells has a little door that needs to open to let the sugar in, and now you imagine that those doors have locks. Insulin's the key that allows that lock to open and let the sugar into the cell through that open door. And so if you have type 1 diabetes, you don't have enough keys. If you have type 2 diabetes, think of it as rusty locks per se. In either case, the doors don't open appropriately and sugar builds up in the bloodstream. So type 2 diabetes most commonly has been seen to affect adults, but we see it in children as young as 10 years or younger. So, and as I've shown, those numbers are increasing. In the case of type 2 diabetes, many times we can utilize therapies that either improve the effectiveness of that insulin or stimulate the body to make more insulin. And so insulin may not be required for these patients. They may have other medications or treatment plans. But when you look at those students that are most at risk for developing type 2 diabetes, if they're overweight, if they're inactive, genetics are a real critical piece of this. Children that have multiple family members that have type 2 diabetes are at really high risk for also developing type 2. So if we get into the nuts and bolts of diabetes management, and this is what's critically important to allow these students to participate really in all of the activities, both academic and other, in the school setting. So even individuals that do not have diabetes don't have a blood sugar that's, quote, the normal blood sugar all the time. It varies, but it varies in a very narrow range. So it's critical to understand that our goal here is really to keep and their blood sugars in a target range. And that target can vary according to the individual child, their age, and a number of other factors. But that need to keep the glucose range in target exists throughout the days, 24/7. So what do we need to manage diabetes in these students? Well, they need to be able to monitor their blood glucose. They need to, particularly for those individuals with type 1 diabetes, we need to manage their insulin therapy. Nutrition, food obviously affects blood sugar, so we need to take that into account. Physical activity also affects blood sugars, we'll speak to in a moment. And psychosocial support is really important for these students. Type 1, managing diabetes, type 1 and type 2 is a burden. And so building in the ability to accommodate their medical needs is incredibly important, and making their school experience as much typical as possible is really, really important. And then addressing emergencies. So we'll speak to those in a moment, but individuals with diabetes can be at medical risk, and we need to be able to recognize situations where that may occur and how to manage those. So managing blood sugars is challenging. If you look at the left side of the slide here, there are a variety of things that tend to raise the blood glucose, certainly food. If a student consumes more food than perhaps they dosed insulin for, and it's a carbohydrate, so the starches, pasta, bread, those most often affect the blood sugar, and if we don't appropriately account for those and they undercount, then they may not provide enough insulin. That's going to give higher blood sugars. Periods of stress, whether it be related to illness or injury or even a big exam, can certainly raise blood sugars. And there are medications, most notably steroids, that also can affect their blood sugar. So they have type 1 diabetes, but also they have asthma and they're on a steroid inhaler or medication. So that's a possibility. And on the other end of the spectrum, you have individuals that can have low blood sugar. So if they've, again, administered too much insulin, that will cause low blood sugars. If they've administered more insulin for food than what they really need. So we really do encourage most students to take their insulin before they eat. So perhaps they didn't finish that entire meal. They're at risk for low blood sugars. And then exercise and activity generally tends to lower the blood sugar, but you need to have insulin around in order to do that. And it depends on the activity. So I always use the example of a child that plays soccer. For practice, they may have lower blood sugars because they're really running around and expending energy. But when they've got a big tournament and they're stressed and they're very competitive, you can have a high blood sugar during that occurrence, but afterwards it may go low. So there's a lot of factors that come into play. So how do we monitor blood sugars? Well, historically, we've used blood glucose meters with finger sticks. So they're simple, they're easy to use. The meters have gotten smaller. The amount of blood required has gotten much smaller, and they're very reliable. And there are additional sites you can do the side of the hand or maybe the forearm to get those blood samples. These meters have memories that allow us to look back at their blood glucose records. We can upload them to computers and analyze the data. We encourage families to do that at home, and they have the ability to do that potentially with school staff as well. So it's looking at that blood sugar, not only at the moment, but being able to look back and say, what have the blood sugars done over periods of exercise or exams, and be able to look at that retrospectively to plan forward. That's really, really important. Now, most of our patients check before meals. We'll go into the particulars with regards to exams and activity and so forth, but what happens in between, so perhaps they're checking 4 to 10 times a day. What you don't know is what happens in between. And so increasingly, we've had continuous glucose monitors. And sorry, Jen, next slide. So what is a continuous glucose monitor? It relies on a little electrode, a little wire about the width of 2 human hairs that goes under the skin, and it monitors the glucose level in the skin, in the fluid in the skin, that is a reflection of the blood sugar. These sensors generally last for 7 to 14 days. They need to be replaced. it operates with a receiver, and that might be a receiver that comes with the sensor by the manufacturer, or they use a smart device, a smartphone, a tablet, perhaps. Typically not a tablet, but they also you can communicate that information to an insulin pump that can display and increasingly use that information. And so these devices provide a blood glucose average generally about every 5 minutes. So instead of 4 or 10 levels a day, we now have the ability to look at in excess of 280. And that allows us to really look at not only retrospectively a lot more information, what happens over the day and night, 24 hours a day, but it also, these devices also have a predictive ability to indicate whether an individual is going to have a blood sugar that's going to be low in a few minutes in the future, and allows us to intervene. Next slide. So with these devices, particularly if they connect, when they're connecting with a smart device that has either Wi-Fi or cellular service, it allows us to be able to remotely monitor those glucose levels. And we can set alarms both for the user, the student, and for either a parent in the home situation or the school staff. And so it's been shown that at home, parents remotely monitoring those glucose levels improves blood sugar control, alleviates a lot of stress and worry. And then in the school scenario, the school nurse or appropriate personnel may remotely monitor as well, and that adds an extra layer of supervision or safety. And so it's really, really important to understand that this is an individualized plan for each and every student. It really needs to be based on their needs, and the providers will include recommendations, or should, in the diabetes medical management plan, which we'll speak to in a moment. There's also guidance available at diabetes.org/SASCGM for Safe at School CGM. Next slide. So, mentioned a little bit about this. Insulin is a hormone. It's made in the beta cells of the pancreas, and it is what allows sugar to move glucose from the bloodstream into the cells. The cells require glucose. And so students with type 1 diabetes generally don't make nearly enough insulin, so we need to provide that insulin. For type 2 diabetes, particularly at the beginning, when they're first diagnosed, they're typically making more than normal amounts of insulin to try to compensate for the fact that that insulin doesn't have an appropriate effect. And so they have what we refer to as insulin resistance. Irrespective, without enough insulin action, high blood sugars result, and that if cells aren't allowed to, or don't have access to that glucose, they have low energy. Increased blood sugars leads students, individuals with diabetes, to urinate more frequently, so they're at greater risk for dehydration, and there are acute and chronic implications, so short-term, long-term complications with chronically elevated blood sugars. Next slide. So how do we deliver insulin? So historically, insulin syringes and vials. We have now insulin pens that are more convenient, also delivered by injection. And then we have insulin pumps or tubeless devices called pods that allow insulin to be stored in a reservoir and delivered through a very, very small, it's called a cannula, into the skin where you normally inject the insulin. And so increasingly, these devices can provide far more flexibility and precision in insulin delivery. So it's important to realize, what the likely emergencies may be. And so again, this is where the diabetes medical management plan is really, really important in terms of how to anticipate when emergencies might occur and ideally prevent. Right? Prevention is key here. Yes, we need to be prepared to deal with the emergencies, but we need to be aware of scenarios where they may occur and be proactive so that the emergency doesn't occur. Next slide, please. So hypoglycemia is probably the most serious emergency that may occur for an individual with diabetes. So we want to know what symptoms are, and they vary according to the student, but in general, mild to moderate symptoms are listed there on the left. They may demonstrate extreme hunger. They may have some shakiness, weakness. They may be pale. They may have some dizziness or feel lightheaded, an increase in heart rate, yawning, which, as the former father of an adolescent, yawning sometimes happens in adolescence anyway, but irritability, frustration, tiredness. And as the blood sugar continues to fall, they may have sleepiness, change of behavior, sweating, anxiety, dilated pupils, restlessness, confusion, and sudden crying. If the blood sugar continues to fall, severe symptoms may occur where that student does not have the ability to eat or drink something to correct the low blood sugar. So they're going to need assistance by someone else. They may become unconscious and unresponsive. They may have a seizure or a convulsion. So we want to avoid severe. We want to address mild or moderate. Next. So glucagon. Glucagon is critical for assisting those students who become unconscious or cannot safely eat or drink something. So glucagon is actually a hormone that's made in the pancreas, in the alpha cells, immediately adjacent to the beta cells that make insulin. And glucagon can be life-saving. It's a hormone that raises the blood sugar. Your liver stores sugar. It stimulates the liver to release that sugar into the bloodstream. So it's available as an injectable, either ready to use, similar to an epinephrine pen. Historically, the old classic glucagon emergency kit requires that there's a powder that you need to reconstitute with some fluid and then give the injection. And certainly school personnel, families have been instructed to do this for many, many, many years. It's also available as a nasal powder. And as I said, it is a treatment for severe hypoglycemia. It's life-saving. It can't harm a student. You can't overdose it. There are some precautions that we take. It can make you feel a bit nauseated. So if a child is lying down and they're given the glucagon, we want them turned on their side in case they do vomit, that they're not going to choke or aspirate on that. So very simple instructions that can be life-saving, and so critically important here. Next slide. So high blood sugars. Now, high blood sugars in general are not as critical an emergency issue, but we need to address them. Address these high blood sugars early on so that it doesn't become a critical issue. So mild symptoms of high blood sugar include a lack of concentration, thirst, frequent urination. It can appear flushed. If it progresses, you can have a sweet, fruity breath that can be noted. They may have some blurred vision associated with the higher blood sugar. Over time, they can have weight loss related to the loss of sugar in the urine and the resultant dehydration. They can have increased hunger, stomach pains, and again, can have fatigue and sleepiness. With continued or more elevated blood sugars, because of that dehydration, they can have dry mouth. They can, as we'll speak to in a moment, experience vomiting and stomach cramps and nausea. And then if the blood sugar really reaches critical levels, labored breathing, confusion, profound weakness, and unconsciousness. Again, prevention is really critical here. We can measure ketones. So for students and individuals with diabetes, particularly those with type 1 diabetes, we want to measure ketones. They are really a sign that the body really is deficient in insulin. So ketones accompany acids that result when the body doesn't have enough insulin. The cells don't have access to that sugar, so they're stimulating the body to break down fat, protein, to make more sugar because they're not receiving that. So in this case, most commonly it's because insulin hasn't been given, or there's a severe stress illness and dehydration. And with this increase in acid level, it can cause severe abdominal pain, nausea, and vomiting. And again, it's critical to realize that individuals with high blood sugars are urinating more, so they need to be able to hydrate. Otherwise, they become dehydrated. And once they become nauseous, they develop nausea and they have vomiting, that's not possible. And that's when they really get into trouble. So without sufficient insulin, ketones and acid continues to build up in the blood, and it can result in what we refer to as diabetic ketoacidosis. And that is life-threatening. Next. Okay, so diabetes care at school. So what's required? So if we go to the next slide here, step one is that diabetes medical management plan. That is the student's healthcare provider, typically in association with the parents, coming up with a plan as to what is required regarding blood glucose monitoring, insulin administration, signs and symptoms of high and low blood sugars, what to do in the case of physical activity, and what nutritional needs are required. So again, the DMMP is available there on diabetes.org/DMMP. And this is really the basis for that student's diabetes management at school. Next slide, please. So it is critically important that the management of a student's diabetes at school really is based on shared decision making, right? So it's the healthcare provider, it's the family, it's a school personnel, but most importantly, it's a student as well. So we firmly believe that students should be allowed to provide their own diabetes care at school to the extent that's appropriate based on their development experience. It's not simply a matter of age. The age at which a student is able to successfully perform self-care tasks does vary depending on that individual. And the extent of their ability to participate in diabetes care should be agreed upon by their parent or guardian, the student's healthcare provider, and the school staff. And the student's capabilities and their willingness to provide the self-care should be assessed and respected. And it's really important. School staff spend a lot of time with students. And even as a provider, I think it's extremely valuable to get feedback from the school personnel as to how well that student is managing their diabetes at school and whether we need to adjust expectations or provide additional support. Next slide, please. So monitoring at school. Again, these students require regular monitoring of their glucose levels before meals and snacks at minimum, including physical activity. It's going to affect their blood sugar before dismissal, before they go home. So per their diabetes medical management plan, they may require additional checks if they have certainly symptoms of high or low blood sugars, if there's been a recent change in their diabetes management where their blood sugars may be different than usual, periods of stress or illness prior to testing. As Jen mentioned, blood sugars do affect cognition. So if a student has very high blood sugar or low blood sugar, that's going to affect their performance on exams. If there's an unexpected early or delayed release from school, we need to monitor glucose levels. And certainly with these devices, continuous glucose monitors in particular, they have alarms. And we want to make sure that we're assessing the blood sugars when that occurs. Next slide, please. So particularly for those individuals with type 1 diabetes, insulin is required at school. So their dosing does vary, not only from student to student, but it changes in that individual student as they grow and develop. As we already mentioned, periods of stress and activity and food, all of those things affect their need for insulin, and their dose changes. So their need for assistance in terms of administering their insulin does vary. And our goal is always to move towards independence as the students get older. Insulin dosing and timing will be specified in the DMMP. That may include provisions for the parent and guardian and/or capable students to modify that dosing. Again, should be outlined in the DMMP. Specific school procedures for administration of that insulin is documented there as well. It should be. Next slide. So nutrition, again, a key part of managing the students' glucose levels. Students, parent, guardian, and the healthcare team generally develop an individualized meal plan for that student. A diagnosis of diabetes does not always limit which foods the student can eat. So that's, we don't want students to be in a position where someone in school is saying, well, you can't have that because you have diabetes. Again, we tailor insulin regimens and nutrition plans for individual students. And that certainly can include treats and sweets. So we want to respect that as well. We need to make sure that we're timing meals and snacks appropriately to balance their physical activity and the insulin that we're administering. We do encourage all students, including particularly those with diabetes, to have a healthy diet. And students with diabetes may need additional accommodations if they've got comorbidities, elevated cholesterol, blood pressure, and weight, and so forth. So nutrition is a key component of their management. So school nurse and others, really the school nurse is most appropriate to really coordinate the diabetes care, to supervise that care, and when available to provide that care directly. They're also really key to communicating health concerns to the parent and guardian and the healthcare team as well. We recognize that the school nurse is not always available, so it's important to realize that non-medical school staff can be trained to assist those students for both routine and emergency care, and that includes insulin administration and glucagon administration as well. So teachers, they support self-care by capable students. That's really important. We want to encourage that independence and with appropriate supervision. They should have easy access to their diabetes supplies. They should ensure that their students are eating snacks at scheduled times per the DMMP, making sure their snacks are available if they do have a low blood sugar, working with the parents to make sure that those supplies are available as well, and then providing them reasonable time to make up missed homework and tests. And this is where the DMMP leads to an individualized care plan or a 504 plan. And so that's really important that, again, their academics align with what's required to manage their diabetes, and supporting diabetes care, providing free access to bathrooms, water during class. Again, students with high blood sugars need access to water. They need to stay hydrated. They're going to need access to restrooms because they're going to be urinating more frequently with high blood sugars. Next. I'll turn it back to you, Jen.
Thank you, Dr. Rodriguez. So now let's discuss some of the legal protections students with diabetes have. And I want to start off with, what does discrimination of students with diabetes at school look like? It could be schools without a school nurse or trained non-clinical school staff members, making the parents come to school to give insulin or provide other diabetes care, children being told they cannot go on field trips or participate in other activities unless their parent comes along, students that are being denied smartphone access to manage their diabetes, students who are sent home early because of blood glucose levels instead of attempting to treat first. And so these are just a few examples of what might constitute discrimination. They're the ones that we mostly hear about from parents and other advocates. Many of these situations have been addressed in lawsuits in federal or state courts or in settlement agreements between the Department of Justice and schools, also with camps and child care centers. So there are 3 federal laws that protect students with diabetes from discrimination. There's the Americans with Disabilities Act, which is also referred to as the ADA, Section 504 of the Rehabilitation Act of 1973, which you all are probably very familiar with as Section 504, and the Individuals with Disabilities in Education Act, which is called IDEA. All 3 of these laws require that students with diabetes receive the care they need to safely access and participate in school and school-sponsored activities, including through reasonable accommodations where necessary. The Americans with Disabilities Act and Section 504 are both anti-discrimination statutes, which means they prohibit discrimination on the basis of disability. Diabetes is a disability under the law because it substantially limits endocrine function, which is part of the diabetes system. The ADA applies to both public and private schools, but not religious schools. And Section 504 applies to any school that receives federal funds, which can include religious schools. Under both laws, the student's disability doesn't have to impact the ability to learn to apply, which I think is important to note because diabetes might not always impact the ability to learn. IDEA makes available a free, appropriate public education to eligible children with disabilities, and ensures special education and related services to those children. Unlike the ADA in Section 504, students must have an impairment that impacts the ability to learn to qualify under IDEA, which is why a lot of times you might see a student with diabetes just have a Section 504 plan, but if they have an additional disability, they might have an IEP under the IDEA. Before we dive a little bit more into Section 504, I just wanted to note that state and local laws can also be relevant in all of this. There are some local and state laws that are more expansive than the laws that I just described and give students more protections. However, when it comes to diabetes, there are some state laws that specify who can administer insulin and glucagon in schools, which might make things a bit more restrictive. In New York, for example, nurses are required to administer insulin, whereas in Texas, there can be 1 to 3 unlicensed diabetes care assistants that have to be trained to administer insulin and glucagon. And we have the specific laws for every state and DC online that you can find. So what is a Section 504 plan? I know for this audience, this might be a pretty obvious question. It's a written document where parents and guardians and the school agree on the services and modifications that the student needs. And each child with diabetes has individual needs. As Dr. Rodriguez says, each DMMP outlining what the medical needs of that student is going to be different. So each 504 plan should be different. Parents and guardians should approach the development of their child's 504 plan proactively and collaboratively with school staff. That is, there should always be a plan, even when things are going well. You never know if the situation could change, or maybe it was always fine in elementary school, but in middle school with testing, things are a little bit different. The accommodations should be reasonable. It's safer that it's all in writing and everyone understands their role. And even that we've talked a little bit about the DMMP or healthcare plan, but this is not a substitute for a Section 504 plan, IEP, or other written accommodations plan. The DMMP just outlines what medical care is necessary. The 504 plan may say how that medical care is going to be administered in other academic and non-academic accommodations that that student might need because of their diabetes. We do have a new sample 504 plan that highlights kind of what we most often see in 504 plans, and that's available at diabetes.org/504 plan. So moving on to some common 504 accommodations and services that we see. The most common ones for students with diabetes is medication administration, both per the doctor's orders and in case of an emergency. And that means training adults at the school, other school staff, not just the nurse, on how to respond in an emergency. With advances in diabetes technology like the insulin pump and CGM, being able to access school Wi-Fi and smart devices is also often an accommodation that we see. And that might look a little different during, the normal school day versus during testing, but there should be an accommodation in place for both. So before we open it up for questions, and I'm glad everyone is putting questions in the chat, so please continue to do so. I just wanted to share a recent case where many of these problems arose. So the ADA, our organization, and disability rights advocates were hearing from families about problems in New York City's public schools. These problems were widespread failure to train staff on diabetes at all levels. Nurses were rarely provided on field trips or extracurricular activities due to nursing shortages. And as I mentioned briefly before, this is important because New York only permits a licensed healthcare provider, like a nurse, to administer insulin. There was also a failure to conduct appropriate 504 planning, which often meant that schools were not prepared to provide necessary services at the start of the school year. So based on this, the ADA and a group of families sued the New York State Department of Education and related departments in federal court on behalf of students with diabetes in the New York City public school system. Disability rights advocates represented the class of students, and the ADA was the organizational plaintiff, since that kind of is who we want to represent. We eventually settled with the New York City Public Schools in April of 2023, so a couple years ago. And the settlement agreement is very strong. It requires the adoption of a template 504 plan to guide schools in preparing to meet the needs of students with diabetes. It also requires a commitment that accommodations can't be denied based on resources or available funding, which is often an argument we may hear from school districts. The settlement agreement also put timelines in place for developing Section 504 plans. These are really important for students with diabetes because it can ensure that students attend school with all accommodations in place in the first day of school instead of having to wait, in this case, sometimes months for those accommodations to be in place. It also required robust training for all staff on diabetes care. We've worked with the city to develop these trainings based on our school modules. And in addition to the settlement agreement, there was specifically a court order during the litigation phase of this process that requires New York City Public Schools to hire a pool of nurses that could assist on field trips or other extracurricular activities as needed, as well as training bus drivers and attendants on some diabetes emergency tasks. Finally, there's a robust monitoring and reporting for a 3-year period. We are wrapping up the first school year in this period, and we've seen some good changes. So that's just an example of kind of how this can come about in real life. I just want to, before now, just go over some key takeaways you can get from the presentation today. So students with diabetes are increasingly reliant on diabetes devices, which require access to cell phones. So let's keep this in mind when creating 504 plans and school policies. There should be individualized care and plans in place for each student. A blanket diabetes policy is not going to work. You might have some templates that you can use, but everything has to be adjusted for each individual student. The school nurse and/or the trained non-clinical staff should be available during the school day and at school-sponsored events to provide care as per written in the plans. CGM remote monitoring that Dr. Rodriguez spoke about can provide an extra level of supervision and may be useful for some students. Hyper and hyperglycemia or low and high blood sugar can be treated at school per the DMMP. And federal and state laws apply to children with diabetes, so they have access to care in schools and are protected from discrimination. We have a wealth of resources that we could not possibly go over within this hour and at diabetes.org/safe@school. And I highly recommend you check them out. We have ones that are specific to school districts, other ones specific to parents that you would find super helpful. So now I will open it up for questions. Thank you everyone who has put questions in the chat. Our first question says, my state, Massachusetts, does not allow delegation of diabetes care to unlicensed personnel. Do you have any suggestions for this? We are making having a nurse at school daily a priority. Yes, so there are a handful of states that do not have delegation permitted. I would say the majority of states do, which is a good thing. And we understand with nursing shortages, it is difficult to get a nurse to be there all the time. However, based on federal law, you would have to have a nurse there during the school day and at school-sponsored events to do the diabetes care for that student or students with diabetes because that delegation isn't permitted. I know that there has been efforts in the Massachusetts legislative and regulatory areas to currently to at least allow unlicensed personnel to administer glucagon in case of an emergency. So if you're seeing that maybe this is something that needs to be a bigger change, you could always reach out to your representative in Massachusetts at your state level and see what they are doing to make this change in your state. But for now, it would have to be the nurse, and there would have to be a nurse there throughout the school day and at school-sponsored events. Henry, do you have anything to add to that question?
I mean, if you think about parents, most parents of students with diabetes aren't healthcare professionals, right? So these are parents that are trained to administer insulin, to monitor blood sugar, to troubleshoot illness, stress, what have you, all of that. And they're not healthcare professionals. Yes, I think it would be ideal that we have a school nurse at every school, but we recognize quite clearly that that isn't always possible. So, the ADA does advocate strongly that there be training of non-licensed personnel in the schools. And as Jen mentioned, that's why, the Safe at School Working Group has historically and every day continues to kind of improve the resources that are available for school personnel so that there is material there that really provides state-of-the-art current training for individuals that can assist students with diabetes.
Thank you. There was a question if this presentation is in Spanish. This specific presentation is not, but we do have many Spanish resources on our website. So I'd recommend going to diabetes.org/safe-at-school, and there'll be an indication on whether there's a translation available of many of those resources that you can check out. Questions?
You want to take the question regarding insulin pumps?
Sure. So the question says, in reference to parents required to come to the school to provide insulin as discrimination of students with diabetes, some school policies do not allow staff to adjust the pumps, which could mean refilling insulin into the pumps if it runs out at school, change the pump if it falls off, and parents are called to come and take care of these issues. Should this policy be reexamined, or is this something different than administering a lunchtime bolus? I think it really depends on the student and if the parent is willing to come and take care of those issues. However, there should always be a backup plan in place in case of pump malfunction. In case, you never know, maybe the parent's at work, they can't get out of work. They're not, close and the child needs insulin really soon. So there is always a backup plan in place as per the DMNP of what the staff should do during that. So when in doubt, go with the backup plan first. Dr. Rodriguez?
Yeah, absolutely. This is a really critically important question. These devices are phenomenal. They have really not only allowed us to improve blood glucose control in individuals with diabetes, but have really lessened the burden. However, as certainly those of us that are longer in the tooth realize, technology sometimes fails. And so coming back to that issue of we want to avoid emergencies, every individual that has an insulin pump that has a continuous glucose monitor should also have, as Jen mentioned, a backup blood glucose meter and either insulin pens, pen needles, or syringe and vial that they can administer insulin. So there's no doubt that, students with type 1 diabetes require insulin. If their device fails, they should be able to administer insulin and, quite honestly, allow them to progress through their school day without the device. Is it challenging? Absolutely, but it's a necessity. Really, the goal here is to allow that student to progress through their school day and participate in all of the activities and their educational learning. So having a plan in place, which, as Jen mentioned, should be outlined in the DMNP, and having the supplies at hand, critically important. Again, preparation, addressing issues before they become a crisis.
Thank you. There's a question about after-school activities. So, what is the responsibility of the school during after-school activities if the physician and parents document that the student is independent? Parents also indicate no need for a nurse on field trips. So if that student is independent, they might not need assistance with, their normal care tasks, but that doesn't mean that they might not need assistance in case of an emergency. So, say they're a track athlete, those coaches or any of the other staff that are going to be at those events, at those practices, should be trained on how to respond to an emergency, how to recognize lows and highs and what the proper treatment is. A lot of the time, if the student's independent and if it's mild, they might recognize it themselves and treat it. But you need to know what happens in case of an emergency. If it's severe, what are the steps? What should they do? Same thing with the field trip. There's going to be some sort of staff on that field trip, and they need to know what to do in case of an emergency. Dr. Rodriguez?
Yeah, again, a critically important issue. We want the students to be safe in whatever school-related activity they're participating in. And so, yeah, we want them to be independent, but there is the risk that they're going to have a borderline or actual emergency situation arise. And I think it is important not only for the safety of that student, but quite honestly, for the fairness of the staff or the coaches or what have you, for them to know what to do. So this is where the training is critically important. And, if you have a student that's very independent, it's not only that the coach needs to hear it once, but if they need to have a refresher so that they're aware, and that can be coordinated through the school nurse, where they have the tools and the knowledge to deal with issues before they become crises.
It's a question on CGM monitoring. For middle school and high school students, is it mandatory for an RN or diabetes care aide to monitor their Dexcom or other CGM? What about after school's hours if you're monitoring during the day? Henry, do you want to maybe talk
Sure,
about this?
sure. So there is actually, I mean, we don't have an actual copy of the DMMP, the current one, which was just recently updated to accommodate just these kinds of issues. So the short answer is, if it is dictated in the DMMP that for whatever reason an individual student requires close monitoring, then that needs to be done. Now, how it's done, I think the devil's in the details. And as you've heard, hopefully, a take-home message here, it's individualized, right? I think currently, the situation where a student needs to be monitored that closely is probably the exception rather than the rule. We have these tools at hand, so it's a collaboration between what the diabetes care team feels is necessary, the family and the school staff coming together to meet the needs of that individual student, and then coming up with a plan as to who to monitor, what kind of communication is going to occur between the school, the parent or guardian, and the healthcare provider. This is all critical to planning up front, so that, again, there's not a question of what to do when something happens. It's we've got this plan in place not only for what needs to happen, but who is responsible and how the individual caretakers and stakeholders, quite honestly, in the care of that student, how they're going to communicate.
Great. There's a question on what to do with accessibility of items. So some, of the tools to manage diabetes are sharp, like a glucose pen maybe, or some of the insulin pens. And it's really important that those things are accessible, right, Dr. Rodriguez? But they also are sharp. Is there anything specific that should be done to keep it on the student and not, behind a locked door in case of a lockdown or other emergency?
Yeah. So again, great question and incredibly important. So you mentioned lockdown. That's probably the extreme situation, right? You have an individual that has diabetes. If they're insulin requiring, they need that insulin at hand. Generally, it is we advocate for students being able to carry their supplies with them. Now, again, this is a discussion that needs to occur with the family, with the school personnel. How are we going to accommodate for the safety of their classmates and other staff and so forth? These are not dangerous items here, right? But there needs to be a plan as to how to dispose appropriately of sharps and so forth. And having the ability to do that upfront, allowing that student, we're asking particularly, excuse me, older students to be more responsible, to have more autonomy in managing their diabetes. And if they have to go clear across a building or in some cases campus to access their diabetes supplies, that's not acceptable. So having a plan in place. And I will mention, you want to take the situation of not even a sharps issue, but a low, treating a low. It is not appropriate to require a student to travel through a building, up and down stairs, across campus to treat a low. They need to have those supplies readily available. And so if there's not, quote, snacking allowed in a classroom for that individual student, they need to have access to whatever juice or snacks or what have you to allow them to manage their blood sugar there. So all of these things need to be addressed in that care plan, their 504 plan, their individualized plan at school to allow them to manage their diabetes safely and fully participate in school activities.
Thanks, Henry. Last question. Could we speak to who and what training can be provided to staff by the school nurse?
So much. So yeah, I mean, we've provided numerous links to all the resources that are available. It is the ADA's position that the school nurse really is responsible for coordinating all of this, ideally with communication with the students' diabetes healthcare team. And so there are plenty of resources available, and would encourage all of you to access those. But they're available to assist school nurses themselves in their own training, but also to assist in their training of non-licensed personnel.
Yep, and you can find, as Dr. Rodriguez said, those training modules on our website, and there are a bunch of different slide decks on different topics covering all different aspects of diabetes care on our Safe at School website. Well, I think that brings us to a close. Thank you all for joining us today. I wanted to give some contact information out if you have any questions about diabetes in school or discrimination of students with diabetes. You can always give us a call at 1-800-DIABETES or email askada@diabetes.org on these issues. This recording specifically will be up and available online on our Safe at School page for viewing in the next couple of weeks. Thank you so much, everyone. Have a great rest of your day.
Thank you all.